Hello, I'm Dr. Vlad Maletic, clinical professor of psychiatry at the USC School of Medicine in Greenville, South Carolina. I wish to welcome you to the first episode in a series of 4 podcasts on bipolar depression entitled, Is There a Quick Way to Differentiate Mood Disorders? My esteemed guest today is Dr. Manpreet Singh, who is a professor of psychiatry and behavioral health at UC Davis in Sacramento, California. So, welcome, Manpreet.
Super glad to be here with you, Vlad. Thanks.
So, Manpreet, you are a world-renowned researcher, but you're also an excellent and experienced clinician. I'm asking you something that is very complex, trying to distill it into a simple question. Tell us about your clinical wisdom, about your hacks. Is there a quick way to differentiate mood disorders?
When a patient comes into my office, anyone presenting with any mood symptoms, I try to always screen for depression and mania. The reason I do this is because you don't really have a complete picture if you just ask one or the other. So then, after I've asked about any mood symptoms, then I'll go down a particular rabbit hole and I'll follow that train of thought with the patient. Then after that, I'll ask if anyone in the family has ever felt cheerful, high, terrific, not their normal selves for continuous stretches of time. And if they say yes, then I'll ask them to describe that. The family history piece is really important because that's another way to engage patients in the conversation. When I go down that path, I'll hear a variety of different things. And at that time, I might even ask about the different secondary criteria after I screen for an index mood episode. Distractibility, increased goal-directed activity, grandiosity, fast speech, engagement in impulsive behaviors, sex, drugs, and rock and roll. The reason why I don't start or lead with that is because it's uncomfortable to talk about those things. But if I can ask just generally about mood symptoms, we can get pretty quickly to diagnostic criteria.
Now, here's a question which you may have heard an audience member bring this up. Given that there are many medicines that have both proven efficacy as adjunct treatment in a major depressive disorder, as well as for some phase of bipolar illness, is it really important for us to differentiate between the mood disorders?
Yeah, well, it's super important because it matters what you do next. And the seeds for shared decision-making really start at the relationship that you establish with your patients, and you get all the information, sometimes even starting in the waiting room when you get an opportunity to speak to family members who might be able to provide some collateral information. Or if the purpose of the clinical interaction is to rule out bipolar disorder, sometimes it's really helpful to at least get that aspect of the screening assessment out of the way so that you can have a more complicated or nuanced conversation afterward. That early branch point can be super definitive about what you do next. Because if it's simply unipolar depression, then you're going to go into a completely different treatment conversation than you would if there was ever a lifetime history of mania. And when you know what you're dealing with, that has implications for how you then personalize the treatment. So you might need to ask, first of all, about safety concerns before you even plan for treatment in an outpatient setting, hospitalization, before you consider any other management strategy, whereas bipolar II disorder might be more subtle, still impairing, but subtle and may or may not require higher levels of care. Then, if you can get to a mood disorder diagnosis, then you might have to ask yourselves whether you're going to treat with psychotherapy or medication. And then we would go down that pathway. So these diagnostic considerations are super important in terms of figuring out what you're going to do next.
You know, in your very detailed response, you mentioned screening. Would you have advice for our audience? What is the most efficient way of screening for mood disorders?
The PHQ-9 or the Patient Health Questionnaire 9 is, or its various forms. Sometimes there's a version with only 2 questions or 8 questions. If you don't want to ask about suicide, can help you screen for depression. Then you have, the GAD-7, which is available for anxiety screening, for example. So our colleagues have developed a very nice rapid mood screener that I think could be very useful. It's been validated against more broadly or more commonly used mood disorders questionnaire, or MDQ. So Vlad, one of the things that I like about the RMS, I know it's not always one that we use at every single encounter, but what I appreciate about it is the value of reminding clinicians to think about mania symptoms when a person presents with depression. The 6 questions that are part of the RMS include things like establishing at least 6 depressive episodes, because the more intense the episodes and more frequent they are, lasting at least 2 weeks, points to potentially something more complicated than a bread and butter unipolar depressive episode. Another factor that it screens for is whether the depression started before the age of 18. I'm a child and adolescent psychiatrist, and I see early onset mood disorders pretending to worsening prognoses and potentially being a hearkening for later bipolar depression. Another hint that this might be more than a simple bread and butter depression is the presence of irritability, hyperactivity, racing thoughts, or more talkativeness. And then, of course, the unusual euphoria, the cheerful, high, terrific, not your normal self, couldn't imagine life being better, or the unusual outgoing or energy aspects of mania. And the fact that it lasts at least a week, where patients might describe feeling like they need much less sleep than usual. These are really cardinal symptoms of mania that really ought to be part of every single mood disorder evaluation if you're going to be comprehensive about it. And like I said, it doesn't take very long to ask these questions, and they can be super high yield to help us understand the difference between unipolar and bipolar depression.
This has been very, very helpful, and I'm sure that our clinician audience will be able to utilize this information readily in their practice. But now there's a different question. You've helped us differentiate bipolar spectrum conditions from unipolar depression. Do you have any tips? How would you suggest that one differentiates bipolar 1 from bipolar type 2?
This is another really important opportunity for us to think about what the continuum of mania symptoms can lead to diagnostically. People in primary practice find themselves having a misdiagnosis, clinically significant depressive episodes, and receive antidepressant treatment and get worse. It's like 1 in 5 patients that present in primary care practices when they actually have bipolar 1 or 2 disorder. And then if you look at the follow-up studies, the natural course of bipolar disorder, many people do present with an initial depressive episode. Almost half of people with bipolar 2 disorder present with an initial depressive episode. And so it becomes very important not only to distinguish from unipolar depression and bipolar depression, but also to understand the different categories of bipolar disorder spectrum conditions. Patients with bipolar disorder often don't have any insight into their symptoms of mania and hypomania. So things that might raise your suspicion about differences between bipolar 1 and 2, of course, relate to the magnitude of the mania. Of course, the time criteria help, because a manic episode is bad enough where you land in the hospital, or is at least a week of 50% of the day or more of symptoms every single day for at least a week. Bipolar 2 is a little bit more subtle, 4 to 6 days, so less severe than bipolar 1. a family history or course of illness or treatment response, mania symptoms and their magnitude and associated features might increase your index of suspicion towards something more complicated. But it kind of helps, again, at least differentiate from unipolar depression. So it merits us as clinicians to ask the follow-up questions about time of mania symptoms, the magnitude of them, the impairments associated with them that can help you distinguish between bipolar 1 and 2. So ultimately, it's really your job to get a detailed patient history to distinguish bipolar 1 disorder from bipolar 2 and unipolar depression.
So an average age of onset of a first depressive episode in young women who go on to develop bipolar disorder is age 18. And the average age of onset of first hypomanic manic episode is 25. So you have a 7-year gap where if we follow DSM-5 to the T, we technically cannot diagnose them because they've not had their first hypomanic and manic episode. And many times you have multiple failed antidepressant treatments. In the meantime, you have functional impairment, you have strong family history. And I was just going to invite your thoughts. What would be the best idea? What do we do in a scenario like that? Because you have encountered it. And again, you have such wisdom and clinical experience that I think that our audience might benefit from that.
It's a very critical issue, and I don't know how you can get around it without asking about mania and depression at every single clinical encounter.
Yeah.
That feels like it's onerous, but it is not onerous because we have given you some ideas here on how to do this relatively efficiently. And I know that people feel that, in a quick clinical encounter, it's very hard to move beyond screening. And if somebody says something that opens a can of worms and you just don't have time in your doctor's office to ask more questions, you can make some at least strategic decisions about whether this patient might merit a more comprehensive evaluation from a psychiatrist. If it's very clear that you've ruled out any of the mania symptoms for now, put a pin in it and think about it the next time around. But just because you've failed or screened out mania at today's appointment doesn't mean that it's gone forever. So that's how I deal with it. How about you? How do you deal with it?
Manpreet, I do exactly what you're advising. It may sound contrived, my answer, but that is exactly it. Just because at one point in time that hypomanic and manic symptomatology that would help us arrive to the correct diagnosis is not there, it doesn't mean that it's forever gone, that it'll never happen. So I think that this is such a pearl. Continue to ask those questions. If you have degree of suspicion, if you have heard clinical information that would indicate the possibility that this patient, and I don't mean to be inappropriate, but is in bipolar waiting room, so to say, do continue to ask those questions. That is, in my mind, so important. The other thing that I do is I even put the patient and the family members on a kind of alert. And I say, please pay attention. If there are days when your energy levels are higher, if there are days when you can get away with having very little sleep, 4 or 5 hours, if there are times when your thoughts seem to be moving too fast, so it's hard to organize them, if there are times when your friends or family members point out that you're speaking too fast and asking you to slow down, it is important that they be all on the lookout for some of these manifestations.
Totally agree.
Yeah. So you've shared with us about screeners. We obviously know about DSM-5 diagnosis. Are there some other tricks of the trade that you have beyond asking questions that would inform us about DSM-5 indicators of a major depressive episode, hypomania or mania. Are there other things that you would ask of your patients that might help you arrive to the correct diagnosis?
Right. So remember, it's not just a checklist, that we really do need to make sure that we're not just asking a series of questions and calling it a day. We do need to think about time criteria. And we mentioned that a manic episode is at least a week, or requires hospitalization. It's that bad. And there might even be psychotic symptoms that might characterize a full manic episode. A hypomanic episode is at least 4 days, 4 to 6 days, but there generally isn't a change that results in impairment leading to something more overt like a hospitalization. You cannot have a psychosis in a hypomanic episode. So a very different kind of phenomenon. But the other piece to think about is the characteristics of the depressive episodes. People with bipolar 1 disorder may have many depressive episodes, but may have none at all, whereas someone with bipolar 2 disorder must have depressive episodes. Similarly, people with bipolar 1 disorder must have manic episodes. You can't have just hypomanic episodes and meet criteria for bipolar 1 disorder. You have to have a full threshold mania in order to meet criteria. So the severity, the time criteria are very important to think about as you make the diagnosis and a correct diagnosis. And then, of course, there's this phenomenon of mixed features, which makes the conversation a little more complicated. And you have to have a few different criteria to meet for the mixed features category or identifier. But simply to keep in mind that there are a few easy principles to think about when you think about mixed features. They are commonly associated with what I like to call the 4 or 5 A's of mixed features: anxiety, agitation, anger or irritability, attentional disturbance or distractibility, and even anhedonia. And what these symptoms suggest are potentially mixed features in individuals with mood disorders, and they might help you appreciate as a clinician that maybe when you have those gray zones or those overlapping symptoms, you don't have to feel so compelled to delineate one or the other. And note that you can use the mixed features specifier as a way to describe what you're seeing. And it has implications for what happens next. A lot of people with mixed features actually have more severe depressions. They have higher rates of substance use, and they have higher rates of cardiovascular comorbidities. So knowing when to see and identify mixed features can be very important for not just an accurate diagnosis, but also making sure that people get treated.
And there's some information, if I'm not mistaken, about the risk of suicidality that goes with mixed features also. So that is very important. When it comes to mixed features, yes, we stick to core symptoms to diagnose the basic mood state, but the wisdom that you're sharing, look at the non-specific and the associated symptoms, because they can be really, really important landmarks. So any last words of wisdom that you would like to share with us?
You bet. Thanks, Vlad. I think that bipolar depression is a very important and underdiagnosed condition. And so it's very important for clinicians to understand how it presents. Bipolar 1 disorder is when there's a history of full threshold manic episodes. Bipolar 2 disorder is when there's a history of hypomanic episodes, but not full threshold manic episodes. And both can have varying degrees of depressive episodes that come with them. When you look at someone at any single point in time, the symptoms of a depressive episode will be the same for someone who presents with unipolar depression or bipolar depression. So that's a critical step or reason why one needs to ask about mania symptoms anytime anyone presents with any mood symptoms. Because it's easy to miss bipolar depression when someone presents with depressive symptoms. It's really oftentimes the first episode for someone who presents with bipolar depression. So if you don't ask about mania history or hypomania history, you'll not get to that. Almost 2/3 of people with bipolar disorder are misdiagnosed, and most often misdiagnosed as having unipolar depression. So if more clinicians can get at more accurate diagnosis, you can imagine how much shorter the time period can be for people to get the right diagnosis and then the right treatment. If you have to wait 10 years before you get the right diagnosis and the right treatment, it's a shame. And so we want to do a better job of getting patients the right diagnosis and the right treatment as soon as possible.
I can't tell you how much grateful and thankful we are to you for sharing your wisdom with us. If we're lucky, sometimes we will get a pearl of wisdom here and there. I think you have assembled the full necklace for us this afternoon. So thank you so much. And I wish to thank our audience for joining us and invite them to stay tuned for our next episode on bipolar depression. Thank you very much.
Thanks, Vlad.